I'm so glad to join you all today through the Zoom, and happy to talk to you about prediabetes and what it means for you, for your health, and for your future. I hope everybody can hear me real good. A thumbs up from it that would be good for me. Yeah, you're good?
You're good.
Thank you. Okay, so I've been, since residency, I graduated in 2016, and I've been working with Valley Medical Group at my Fairlawn office. Since I'm board certified in family medicine, and diabetes is essentially my bread and butter. So let's get to work. So my first slide, I'm trying to get in there. There we go. So most of the slides that I'll be talking to you about today is from the ADA website, which is the American Diabetes Association, and some of the graphs or pictographs that you'll see later on might also be from the CDC website. So what we're going to talk about what is diabetes, prediabetes, what are the risk factors for diabetes, and how can you delay or prevent diabetes. So what happens when we eat? A quick nutshell. In the picture, it looks like a good Thanksgiving meal, right? So after eating, most food is turned into glucose in our body, the body's main source of energy. What happens, and here's a quick picture of the pathophysiology of diabetes. So when you eat, your body breaks down the food into glucose. The glucose is a type of sugar that your body uses as a main source of energy. And as the blood recognizes the rise in glucose, the body signals, sends a signal to the pancreas, and that's essentially the main organ that supplies and releases the insulin. Now, what happens after that is in the bloodstream, you'll see the glucose is taken up, and what happens, the insulin becomes the unlocking receptor. So as an actin key, the insulin binds to a place on the cell wall, unlocking the cell so glucose can pass into it. And therefore, most of the glucose is used right away as energy. Now, as blood glucose goes up and down throughout the day, so after eating over here, between meals over here, you'll see a rise in glucose after you eat. When that happens, the pancreas sends out the insulin keys. And then as the body and the bloodstream and the rest of the organs take in the glucose, you'll see the slow decline. And in between the meals, that's when the liver is able to produce glucose to help you maintain. So as your blood glucose level rises after a meal, the insulin gets released from the pancreas. Now in diabetes, let's talk about what happens. Why is it that sugar level remains so high? Why is it not declining as this prior picture that we talked about? So in glucose, there are several reasons. One of them, the liver is just making too much glucose in itself. The insulin remember the key, the insulin that we need to retract the sugar from the bloodstream to supply the different organs. Now that insulin is just made too little. And the other one finally is the insulin is made, but the cell wall is not recognizing it. So it's there, but it's not recognizing it. It's what we call insulin resistance. So what are the symptoms of hyperglycemia, meaning too much sugar in the bloodstream? Most oftenly, and this is chronic, you'll see increased thirst, increased frequency of urination, blurry vision, feeling more tired, slow healing of wounds, frequent urinary tract infections or other infections for that matter, weight loss, nausea, and vomiting. There are two main types of diabetes, and then this is as simplistic as as we're gonna talk about it. Type 1 diabetes, pancreas makes too little or no insulin. That's type 1 diabetes. Typically, you diagnose this earlier on in the age, usually below the age, most commonly below the age of 20. And what it is the autoimmune cells are, for lack of better words, going berserk. So your body is attacking itself. As your body is attacking the pancreas itself, it's almost eating up the pancreas so that the pancreas are not able to make the insulin anymore. Now in type 2 diabetes, what happens is the insulin is made, the pancreas is doing the job, but now there's insulin resistance, meaning your body is not recognizing that key. Remember the picture that we saw earlier, that key, the body's not recognizing that insulin. And then as a consequence, more insulin gets produced, and then that becomes almost like a negative feedback. It starts to attack the pancreas because the pancreas just keeps building insulin. It doesn't realize why the sugar is not getting in. So it keeps building, and over time keeps attacking the pancreas in itself, chronic inflammation. And then, of course, the pancreas essentially start to shut down, which is a chronic thing, not in the acute phase, a chronic thing over several years. And then finally, the insulin gets produced in a decreasing level over time. So what are the risk factors? And this is really the talking point and the bread and butter of this talk. What's the risk factors for type 2 diabetes? We're not going to talk about type 1 diabetes as much, and I'm going to focus more of mine on the prediabetes and type 2 diabetes. I will mention, because we did talk about, the talk about this, there was a little bit of genetics involved. Now, type 1 diabetes, I just wanted to say up front, yes, there is a genetic linkage, but there's also an environmental factor there. The most common studies that you can see, or the best way to say, oh, is this fully genetically linked, is studying twin studies. And it was less than 50% chance that one twin will have it and the other twin won't have it, even in a monozygotic, meaning identical twins. So there is a linkage. We don't know quite sure, but there's also predisposition, including viral infections from a young age. The other ones that I was reading about showed nutritional effects in infancy. Breastfeeding decreased the incidence of type 1 diabetes in babies all around. And the other one I saw was climate. Cold climates increase the risk for type 1 diabetes compared to warm climates. Now, let's shift our energy back to type 2 diabetes. So again, type 2 diabetes, most common, right? This is the one that we're all trying to avoid. This is our talking point, the cost. We'll talk about the cost and long-term issues that are associated with it, prevalence of disease, complications of disease, and what it implies for your future. Most commonly seen in overweight, 45 and above of age, physically inactive. This one more so seen with a genetic predisposition, and parents or siblings with the type 2 diabetes increases the risk that you alone will be at a higher risk to catch it. More commonly seen in African American, Native Americans, Hispanic, Pacific Islander, Asian Americans. Usually associated with abnormal cholesterol levels. Has a predisposition for gestational diabetes or when you give birth to a baby greater than 9 pounds. Now, not all gestational diabetes increases the risk for type 2 diabetes, or say that if you had gestational diabetes that you will get type 2 diabetes, no? But it does increase the risk for diabetes at a later point in life, and also may or may not have a high blood pressure. So this picture graph, very, very important. And the obesity trend in the United States of America is a true reflection of how this country is moving with regards to diabetes, prediabetes, and all the complications. So this picture was from 1991, and I took this from the CDC website. No data in some of the states. This is the white, and the darker ones, now remember the numbers, 15 to 19%, the darker color. This is in 1994. Again, this is BMI greater than 30 or obesity trend. Now, if you looked at 15 to 19%, now more darker blue, right? This is 2000. We need a new color scheme, so more dark, much more, and then greater than 20% now with this lighter tone. This is 2000. Again, obesity trend. This is 2006. Again, this became more, so 20 became here. The 25% became in the darker orange, and then the higher numbers became this mid blue, the greater than 30%. And this one, actually, I was able to pick it from the website, from the CDC website today. Unfortunately, the color scheme is much worse. Surprising, Colorado typically seems to be the lowest, but the US obesity prevalence was 42.4% in 2017 to 2018. And if you look at it, 40% is this darker color, and you'll see where that runs, unfortunately. Oops. So now this is the diabetes trend. Why is this not showing up? Okay, this is the diabetes trend among US adults, including gestational diabetes. That's a picture that I showed before, but instead of the obesity, this is for diabetes. So this is 1990. Look how the darker blue now spread over here in 1995. And this is 2001, and the more so with the red at the 8 to 10%, and the greater than the 10 down here. And this is in comparison with the obesity trend. So I wanted to show you the 1991s that you'll see the darker, and then that will be reflective. And each year as it goes past, unfortunately, the trend is moving further, and this is 2010. So now let's talk more for today. This one, ignore this 2011 one. I just picked this from the CDC website, so this is quite new. Unfortunately, for this year, we have 34.2 million people in the United States. That's 10.5% of the population who currently deal with diabetes. Diagnosed is 26.9 million people. Undiagnosed, about 7.3 million. 88 million between the ages of 18 and older have prediabetes. That's 34.5% of the US population. 65 years and older are 24.2, unfortunately. And diabetes is the 7th leading cause of death in the United States. And actually, it might be underreported. This slide is maybe 2 years old, so 2019. In New Jersey, diabetes epidemic, 862,000 people in New Jersey, 11.3% of the adults have diabetes. Of these, 235 have diabetes but don't know about it, and it greatly increases their health risk. In addition, 2,400,000 people in New Jersey, which is 37.1% of the adult population, have prediabetes, with blood glucose level higher than normal, but not yet high enough to be known or diagnosed as diabetes. So this is 2,400,000 people in New Jersey alone that we're talking about. Every year, an estimated close to 40,000 people in New Jersey are diagnosed with diabetes, and diagnosed diabetes costs estimated about $9.2 billion just in New Jersey alone because of the seriousness, because of the increased risk of heart disease, stroke, amputation, end-stage kidney disease, blindness, and of course, death. So let's talk about diagnosing. How do you diagnose diabetes? What are my numbers? How does this mean, right? Normal level, if you look at the fasting blood sugar, is less than 100. Pre-diabetes, that's our main talking point, between 100 and 126, excuse me. Greater than diabetes is persistent fasting blood sugar greater than 126. Not just one day, not just 2 days, it's persistent, and you'll see. With regards to A1C, this is the talking point over here. This is from the ADA guidelines. This is the American Diabetes Association 2015 guidelines. And the A1C for prediabetes is between 5.7 and 6.4, because 6.5 and higher is considered diabetes. So what is your fasting blood glucose, and when was your last glucose checked? That's an important question to ask. Usually with your medical appointments, and especially if you are seeing your doctor for an annual checkup, typically they will run your fasting blood sugar, and if not, make sure that you ask them about it. And especially more so if you are the age group of 45 and older and overweight. 45 and older or not, ask your doctor if it's needed. Under 45 but not overweight, then you have to think about what are the other risk factors that might predispose you. Risk factors, as we said, with diabetes and prediabetes, the fact of genetics becomes much, much more involved. And the talk of which is my gene that I need to test, I'm not going to go into that today because we still don't have one particular gene that we say this is the one that, in fact, there's many more that they're still researching. They haven't found the right, but they're saying there are several that are linked to prediabetes as well as diabetes. So the strong family history, as we mentioned, parent, brother, sister, first generation, or first degree, as I should say. So if one person, a first degree, is your parents and your siblings. Your grandparents are not what we call first degree, they're what we call second degree. So a parent, brother, or sister definitely puts you at an significantly increased risk for you to catch or for you to develop prediabetes or even diabetes. The other race that are very strongly associated, African American, Hispanic, Latino, Native American, Asian American, or Pacific Islander. Like I talked to you about the gestational diabetes, if you had a baby weighing more than 9 pounds, or if you yourself had gestational diabetes, If you are a patient with increased blood pressure, with high blood pressure greater than persistently, not one-time reading, persistently greater than 140/90. If you have a low HDL, which is the good cholesterol, less than 40, that's a problem. If you have high triglycerides, persistently greater than 150 or higher, also increases the risk for prediabetes and thereby diabetes. So if you have prediabetes, what does it mean? It means that you might get type 2 diabetes soon or sometime in the future. Your predisposition to progress is high, and thereby more likely to have the risk factors associated for increased heart disease or a stroke. So now, why are we beating this bush? Like, why are we talking about this so much? And as I showed you in the slides before, forget the cost, but it's also the morbidity that's associated with it. The increased risk for high blood pressure, increased risk for cancer, increased risk by 15%. And the common ones that are linked with diabetes are stomach, colorectal, liver, pancreas, breast, and endometrium. And also Alzheimer's disease and dementia. So let's look about what we can do to help, right? It's all about decreasing your risk factor. So yes, you are born into a family. That risk factor is something you cannot change, right? Now let's talk about things that are in your control, what you can help alleviate and decrease your risks to develop type 2 diabetes or improve your pre-diabetic status. So it's recommended, the ADA recommends at least 150 minutes per week of moderate intensity, which means when I always ask them, what is my moderate intensity aerobic activity? It's about 50 to 70% of your max heart rate and spread over three or more days. Resistance training more than twice per week, and then decreasing your sedentary time. I've seen a lot of patients with the phone or even the watch that says time for you to walk, and I pretty much like that. The goal, if you're looking at step count alone, would be 10,000 steps per day. Okay. So this I thought was very, very eye-opening, at least for me, and my husband and I, we were talking about it just a bit ago. The Diabetes Prevention Program study, very well studied program, and gives us a lot of info on what we can do. 30 minutes a day of moderate physical activity along with 10% weight loss produced a 58% reduction in diabetes. Now, 5 to 10% doesn't sound like a much, or maybe it is too much. So let's talk about what that 5 to 10% means. If you weigh 150 pounds, that means 8 to 15 pounds of weight loss. If you weigh 250, that's 13 to 25 pounds. So it's not impossible, but this activity that we talked about, along with the diet and the exercise consistency, you will see with that reduction of even just 5 to 10%. We're not even asking for a higher number. And that was the best part of it. A low number of weight loss from 5 to 10%. Just imagine 58% reduction in diabetes. I mean, that's remarkable. That statistic can speak for itself. So the question is, how much do you weigh and how much is 5 to 10% of your weight? And this, if you want to click a picture of it, go right ahead, or you can also Google what your 5 to 10% will look like. But this was very easy and a good goal, I would say. So lifestyle modification, that's really what this all comes down to. My patients often ask me about, do I follow a diet plan? What about the fad diets? And to be honest, it's great for a quick weight loss, but it's just not sustainable. And that's the sad part. You lose the weight and you'll see a quick weight loss because a lot of it is water weight, but you're not able to maintain that weight loss because you go back to the previous eating habits. And so lifestyle modification is really the honing point through all of this. Several ways that people have tried to accomplishing it: reducing your caloric in 1,000 kilocalories, reducing your dietary fat, limiting sugar, sweetened sugar beverages, increasing your dietary fiber, whole grains, and 5 to 7 servings of fruits and vegetables a day. So I always tell my patients, I have a quick and dirty way to tell you the plate method, right? So if you have a round plate, divide it in half and then another, the half of your plate should be for your non-starchy vegetables: spinach, carrots, lettuce, greens, cabbage, green beans, broccoli, cauliflower, tomatoes. Of course, do grilled, sauteed salad more than the fried. Now the other quarter, grains and starchy foods, whole grain breads, whole wheat, whole grain, other food, and high fiber. And the other half for your protein, chicken or turkey without the skin, fish, tuna, salmon, cod, catfish, tofu, eggs, lean cuts of beef, and pork. And this lean cuts of beef and pork, I can't stress enough. So when you talk about diabetes, you'll probably hear about glycemic index, and it's not typically a talking point that I give to my patients when I see them. But in a setting such as this, when you can go a little bit more detail, it might be something worthwhile for you to research a little bit more. But preferentially picking more food groups in the lower glycemic index. And if you're looking for a number, it's less than 55 out of the 100. If you Google it, it'll tell you, and I try to put that picture in, and my PowerPoint was giving me trouble all day today. So a picture, if you look into glycemic indexes, you'll see an array of food from the higher hundreds to the lower 55s. And just a few that I actually manually wrote in was multigrain, pumpernickel bread, whole oats, legumes, apple, lentils, chickpeas, mangoes, yams, brown rice. I have on the lower end of the glycemic index. With regards to the fats, preferentially decreasing the saturated fats and the unsaturated fats, cutting back or even avoiding processed meats. When you're looking at protein, look with the low saturated fats, fish, egg whites, beans, and then limiting the saturated fats like butter, fatty red meats, tropical plant oils, fast food, etc., and trans fat. Try to choose low-fat dairy products or even fat-free. You know, there is a patient of mine, just doesn't like to drink water. So I was under the impression that he was drinking something else. And turns out he was drinking milk. He drank about 8, 7, 9 glasses of milk a day. And the talking point with that person was, your body does not need it anymore. Yes, you needed it when you're a younger age, but now your body does not need all that nutrients. And then finding a replacement. Now, whether it was the taste of the milk that person liked, finding a healthier alternative became a problem. Now, a lot of my patients, I see a problem is like sodas, different types of sodas or different type of drinks that they enjoy. And so once we took that portion off, we saw a significant decline in their pre-diabetic numbers. When you look at the micronutrients, we rarely say that you need to take a particular supplement unless we know that you are deficient in a supplement. But otherwise, usually with a healthy eating plan, you'll get enough micronutrients. So now what are the prevention, again, for the recommendations for prevention or to delay type 2 diabetes? And again, this is just a summary of everything that we talked about. Encouraging a structured program, nutrition counseling, weight loss education, and exercise regimen programs. For some particular patients, your doctor or your provider might discuss metformin therapy, especially if you are considered much more higher risk to go into full diabetes, and whom that might be if a BMI of greater than 35, age less than 60, women with prior gestational diabetes, or even with all the lifestyle interventions that we've tried, the A1C keeps rising. And metformin is our mainstay of treatment. Monitoring at least annually for the development of diabetes in those with prediabetes, and usually we do that with blood work. And screening for treatment for modifiable risk factors for cardiovascular disease, as we mentioned before. Now, why are we talking about this so much? What does diabetes do? Why is this such a burden? The long-term complications, aside from the short-term, long-term, it increases the risk for nerve damage or neuropathy. You'll see issues with feet and hands, heart and circulation, and other organs where the nerve damage causes significant pain, especially with the hands and feet. heart circulation, poor circulation, increased risk for blood pressure. Stomach, bladder, and sex organs. The drive is less, the contraction of the bladder is less, and stomach, of course. Now, the small vessel or the microvascular complications can lead to blindness, which is why once a year, if you are diabetic, we recommend to see an ophthalmologist for a retina check. And with the blood work with your physician, they'll usually check for kidney disease and the status of your kidney. So getting your regular medical care, A1C, typically if you are, now this is in the diabetic range, typically 2 to 4 times per year. Blood pressure, the usual check is at least twice per year. Cholesterol will be checked at least once or twice. Dilated eye exams, definitely once a year. Foot exams, once a year. Dental exams continue twice a year. Urine albumin creatinine ratio, and that's the one that shows you the increased risk to develop kidney disease, once a year. We recommend flu shot once a year, pneumococcal vaccine once below the age of 65. Then Prevnar 13, which is one of the pneumonia vaccines at 65, and the second one at 6. And currently now with COVID vaccine, yes, I do recommend my patients to get either the Pfizer or the Moderna with the 2-dose vaccines for all my patients. And then currently the CDC recommendation for the 3rd booster is if you are up to 8 months past your first set of vaccine only for the Pfizer. For the Moderna and the J&J, they're still researching and we don't have an update on that quite yet. Any questions?
Thank you, Dr. John. Yes, we have a few questions that came in. So the first question is, what is more important as a diagnostic tool, A1C or fasting glucose?
Where was that question?
It's actually in the chat if you're trying to find it.
Yeah, okay. Which one is better, A1C or fasting glucose?
Yes.
So fasting glucose is a static number. That tells you what your sugar is doing within that past 8 hours. Your A1C is your average of 3 months. If your doctor is suspecting prediabetes, or if your doctor is suspecting diabetes, the gold standard at this point is getting the A1C.
Great. And then can you just repeat the normal A1C and the pre-diabetic ranges?
Sure. So normal A1C is 5.6 and lower. Pre-diabetes is 5.7 to 6.4. And diabetes, unfortunately, is 6.5 and higher.
Great. Okay. And then does reduction in diabetes, does that mean a reversal of diabetes? Does it mean that a diagnosis of diabetes might be retracted?
So that's a tricky question. Unfortunately, once you're diabetic, you're diabetic. But you are a diet-controlled diabetic or you are a medication-controlled diabetic.
Okay.
Because that chronicity of that problem and that increased risk almost stays in the background. But it's about how you're controlled. That's what it comes down to.
Okay. And then there's a question about fruits. I guess there's a lot of complaints that foods like bananas increase the sugar. Is that true?
Yeah, so I again, I had all this nice pictures that I had figured out. So I was reading up on that, and then it's usually the overripe, especially for banana, if you're talking about it. The overripe, so there was like a good, almost like a meme that I found. The brown ones, the ones that you are, more ripe, I guess, has less fiber, more sugar. But the ones that are more yellow will probably have the less sugar, more fiber. So if you're looking for fruits, try to avoid overripe fruits. Get the ones that are just right, because that overripe ones, the fiber content, and I showed the slides before, once the fiber content drops, it increases sugar right away.
Got it. Do vitamins A, C, and E and CoQ10 cause problems if you are close to diabetes or if you are diabetic?
As a normal supplement, no. There are also discussions about if you're taking a statin medication, does that increase the risk for diabetes? The risk reduction in all of those cases with, especially in a statin, I guess, kind of like overarches the problem that you might have with a diabetes diagnosis. So I don't think a normal supplement in a multivitamin increases that significantly enough to have a conversation about it.
Okay. And then are artificial sweeteners okay to use for prediabetes?
I'm not an artificial sweetener type of person, to be honest. In my own patients, I try to avoid the artificial sweeteners, only because the testing for what it can do later on are still not there fully. But yeah, can you take it? Yes, yes. But I'm not. I rarely recommend artificial sweeteners just to my patients because of the long-term study has not been done yet. So
Okay. And then
Foreman.
metformin safe to take? And are there any side effects?
Of course, medication, any medication, right? Side effects always exist. Now tell me what reason why you're taking it. Prediabetes, remember I showed you a slide about there's a very small percentage of people that we even recommend take metformin in a pre-diabetic stage. But in the diabetic stage, it is actually the first line drug treatment for diabetes. Why do we say first line? Because it's been studied over and over again, and it gives you the best result for the reduction, and even with the side effect profile, best result in reduction. So it's metformin is always the first line for diabetes.
Okay.
And side effects for that, most commonly patients talk about GI side effects. Usually we start a patient on a low dose for the first week, see how your body adjusts to it. And then usually for the second dose, we increase the dosage. But again, it's our first line agent for a reason. It's been studied, validated several times. The first line agent for type 2 diabetes is metformin.
Okay. And how important is it to count carbohydrates as opposed to following the guidelines you mentioned for a healthy plate?
Yeah, so it depends on the type of person you are. Some of my patients are very good and they're diligent of carb counting, they're diligent. But if you look even at the ADA website, there's different ways to figure it out. It just depends on the type of personality you are. Some patients like to have numbers down so they see. Other patients just are not able to follow through with the carb counting, and in fact, it kind of backfires because they're so overwhelmed. Not that one is better than the other, it's more of the consistency. If you're the type of person who can do it, that's okay. But the round plate, it's a more easier way, it's more visual. It's just easier to follow through. But the whole idea being whichever one you use, the consistency is the bottom line.
Okay. And then is it better to just eat 3 meals each day or like 5 smaller meals?
So to define what are you eating for those 3 meals. But if you're looking for a lifestyle modification and if you're looking for weight loss, typical guidelines or typical recommendation, even by a nutritionist, is to have smaller meals and appropriate snack in between. So you could have your 3 meals, but you'll have smaller meals and then you'll supplement with the smaller snacks in between, which will be your 5.
And then, okay, so then, sorry, there's so many questions coming in. How does prediabetes affect your skin?
How does prediabetes affect your skin? Long-term wise, it's almost like diabetes, right? It's how long, it's all the chronicity of it. Diabetes, it's microvascular, long-term issues. So the touching, the skin, the wrinkling of the skin, the smoothness of the skin. And some patients you'll see even thickness of the area around the neck area. In African Americans or the darker skin patients, you'll see darkness of the skin. It's called acanthosis nigra. So pre-diabetic stages, it's usually a good indication, especially in those races for a doctor, even visually. But long-term, it's more microvascular issues. So wrinkling, elasticity of the skin. Yeah.
Okay. My father was diagnosed with pancreatic cancer and now has diabetes. Can the cancer actually cause this to happen?
So that's what I was talking about earlier. Like, what's attacking your pancreas? That's the question to ask, right? So in type 1 diabetes, where the body was essentially fighting its own cells, and it just kind of gave away, the pancreas kind of gave away. Now, when it comes to a pancreatic cancer patient, what ate away that pancreas? And in that particular case, unfortunately, it's the cancer. And now when the cancer cells overgrew and multiplied, the actual cells of the normal cells of the body that are able to make the normal insulin got replaced with the cancer cells, and thereby leading to the diabetes. So it's not saying that the cancer cells are giving diabetes. It's that now the cancer cell has replaced the healthy cells that was making the insulin. So it's a question about what attacked the pancreas and the cells.
Got it. Just another question or two before we end. And I know there's a lot of questions, and I apologize.
I'll try my best. Yeah.
Okay. What if metformin does not agree with the patient, and there are lots of side effects like upset stomach? Is there anything else that patient can do?
Yeah, so I'm assuming we're talking about type 2 diabetes, not pre-diabetes at this point. In type 2 diabetes, yes, there are several cases where patients are, even though metformin is our first line agent and gives us the best bang for the buck, is an easy way to say it. There are cases when patients just do not tolerate, and that's a discussion that you need to have with the provider. Like I said, they usually give it a few weeks to see how you tolerate. Sometimes we might even say give it a month more just to see if your body adjusts to it, because we just know how good that drug works and how well it'll give you a result for the future. But if it doesn't, yes, medicine has changed drastically in the last 5-10 years and whatever. We're not short of treatment, thankfully, for type 2 diabetes, and your provider will talk to you about several other medications, including injectables if they have to, without non-insulin injectables even.
Okay, just two more questions.
Yeah.
First one, how do you reduce insulin level if it's high on a blood test? And is it possible to get blood sugar level with a home test, like an accurate one?
They do have diabetic screening tools. Like, I've seen patients do that as well. Is it accurate? I'm not sure. You just have to look at their background studies to see how well it is, but it's a good indicator. That's for sure. It might be off by a few points. I'm sure, by few points, I'm sure. But we usually go by the finger stick, which gives us the sugar at a static point. But I have seen A1C used that way too. It's a good indicator. Let that not be your final judgment. Let a proper blood work with your provider be the end all. But that might be a good thing to do if you have it at home, or if you're going to like a health talk or something, and they can prick you and tell you. It's a good indicator, but not like the diagnostic that we choose.
Okay. And then how does breastfeeding affect chances of diabetes?
So there was a study that was done. Breastfeeding decreased the incidence of type 1 diabetes in breastfeeding babies compared to the non-breastfeeding counterparts. Yeah, it's actually a well-studied. I tried to put that on there, and I think they released in the 1990s, if my memory was right, or early 2000s. But it was a well-studied study, and compared to the counterparts, a breastfeeding or a breastfed baby had a decreased likelihood to catch or to develop, diabetes in the future.
Great.
Why it happened? I guess there's a lot of environmental factors, there's a lot of factors that go into it. But the study was fascinating that it did.
Great. Thank you so much, Dr.